We're hosted through New Mexico, but mainly through iEcho in India. And this is our weekly session. Today, we're going to cover a topic that's highly relevant to practice in sub-Saharan Africa because of the high incidence of tuberculosis still running around and still running around in South Africa as well, and posing problems in very many ways. So we'd be very interested to hear on the modern take on what's happening with ileocecal tuberculosis. And Dr. Sibiya is going to enlighten us on what we should be doing with these aspects. So over to you, Dr. Sibiya.
Sorry, thank you, Prof. As Prof has said, I'm Dr. Sibiya. I'm from Albert Lutuli. I'll be presenting on ileocecal Crohn's. Not ileocecal TB, sorry. Can everyone see my presentation?
Yes, we can.
Please go ahead.
So I'll start with a small case presentation of a patient we treated a few months ago. She was a 26-year-old female referred to us from her base hospital in Mahatma Gandhi for endoscopy. She had a 6-month history of epigastric pain and bloating, self-diagnosed as peptic ulcer disease, and started on a PPI. Also associated with unintentional weight loss and anorexia, dysphagia to solids and odonophagia, change in bowel habits in the form of constipation, no diarrhea or GI bleed, no constitutional symptoms of TB or malignancy, no significant family history or social history, and or gynae history, and she was RVD non-reactive. On examination, her vitals were normal. She had no pallor, but she was wasted. She was in ASA 1 to 2. Abdomen was soft. She was tender on deep palpation, the epigastrium, with no peritonism or organomegaly. The systemic examination was non-contributory. On her hematological investigations, her white cell count was 7.6, HB was 11, and platelets were 496. The urine electrolytes were normal. Liver function test, the only abnormality was an albumin of 25, with an INR of 1.2 and a normal CRP. The chest X-ray showed no free end of diaphragm, was essentially normal. The abdominal X-ray showed fecal loading. The abdominal X-ray showed fecal loading, but was grossly normal. Appendoscopy up to D3 was normal. She was still complaining of abdominal pain and bloating and generally just feeling unwell. The team decided to do a CT abdomen and tumor markers, which were normal. On the CT scan, you can see the 2 images that I've put up. They saw a heterogeneous enhancing mass in the ascending colon, cecum, and terminal ileum. It was circumferential, eccentric, and involving the approximately 5.2 centimeters of the terminal ileum and the ascending colon across the ileocecal valve. There were features of bowel obstruction. She had numerous ileocecal lymph nodes with central necrosis and mesenteric lymph nodes. The conclusion from the radiologist report was the features are suggestive of colon cancer with extensive regional lymph nodes. We proceeded to do a staging CT, which showed no metastases and normal CT chest. She underwent colonoscopy based on the CT reports. The colonoscopy showed, she underwent colonoscopy, which showed, as you can see, this polypoid lesion that's obstructing the lumen. We couldn't bypass it with the colonoscopy. She underwent 3 biopsies. This is because the first biopsy, the conclusion said the features are those of chronic ulceration with granulation tissue, which may impart a polypoid architecture. There are no granulomas or infective changes. There's no evidence of neoplasm in the biopsy. And they suggested we repeat the biopsy if we think the patient's got malignancy. Repeated a biopsy, the results still came back as non-specific chronic ulceration, no granulomas, no features of neoplasm. The third biopsy showed the same thing. So the patient then underwent a robotic right hemicolectomy, as you can see in the first picture. The second picture, the middle picture, shows these large mesenteric lymph nodes, and the third picture is of the liver looks normal, and this is the patient's abdomen post the right hemicolectomy. So the histology came back as what they saw in the histology was that on the cut section, an ulcer that involved the cecum and ascending colon was noted with 7.3. It was 7 by 3 centimeters. The ulcer was noted 4 centimeters in the closest margin in the large bowel. And also was also identified within the small bowel, measuring 4 by 1.5 centimeters. They saw 14 mesocolic lymph nodes they identified. The final histology came back as extensive necrotizing granulomatous inflammation was identified in the terminal ileum, colon, and mesocolic lymph nodes. The resection margins were viable. There were no acid-5 bacilli, fungi, or parasites. No dysplasia was seen. The main consideration for this necrotizing granulomatous inflammation was that of tuberculosis. So isolated colonic tuberculosis is rare. It's 2 to 3% of patients with abdominal TB have isolated colonic involvement. The most affected sites being the ileocecal region, the transverse colon, followed by the rectum and ascending colon. Symptoms and signs are non-specific, and early diagnosis and management is difficult. On colonoscopy and biopsy, the features are variable, and the distinction from conditions such as Crohn's disease or cancer may be impossible without surgical resection. So the etiology can be from hematologic spread from a distant foci, from sputum ingested by the patient with active pulmonary disease, from ingestion of milk products infected with Mycobacterium bovis, or from lymphatic spread through infected lymph nodes, or direct extension from contagious sites. The terminal ileum and the ileocecal valve are the most commonly involved segments because of a combination of factors in the region. The narrow lumen, the relatively increased physiological stasis, allowing for absorption of organisms, the minimal digestive activity, the presence of M cells in the lymphatic tissue that can take up bacilli, can take up tubercle bacilli. So in the small intestine and large intestine, there are 4 major forms that have been reported, these being ulcerative, hypertrophic, ulcerohypertrophic, and fibrous stricturing. The patients generally present with vague abdominal pain, fever, diarrhea, loss of appetite, loss of weight, bleeding per rectum, form of maybe frank blood or melena, abdominal mass in the right iliac fossa, or complications of TB such as perforation or obstruction. In more than 2/3 of affected patients, there will be no evidence of pulmonary TB. So although considered a disease of the developing world, in the developed world, they continue to see cases because of migration and in immunosuppressed individuals. I think we have HIV that is endemic in our patient population, or therapy related due to anti-TNF or steroids immunosuppression. A majority of cases of tuberculosis in TB endemic regions may have no identifiable predisposing factor. So it is a great mimic of other conditions, TB, ileocecal TB. It can mimic colon cancer. As you can see in these case reports that I came across in the literature, that they reported where the patients present with ileocecal TB, and just like our case, they were convinced it was cancer. The patient underwent a right hemicolectomy, and only to find that the patient has got TB. And what these case reports concluded is that in cases that are endemic of TB, we should be actively looking to exclude TB in patients, especially in those that when you do the colonoscopy, the biopsy doesn't prove cancer. Then it can also mimic Crohn's disease, and distinguishing TB from Crohn's is difficult due to the similarities in clinical manifestations and poor sensitivity of microbiological tools for diagnosing TB. A South Korean study showed that around 11% of patients with GIT TB were misdiagnosed as Crohn's disease, while 18% of Crohn's disease patients receive the diagnosis of TB. So implementation of the wrong therapy can be dangerous due to the possibility of complications and treatment delays. This is because of the risk of disease progression and stricture formation in Crohn's disease, and the adverse effects of including hepatotoxicity due to TB treatment. So if you misdiagnose the patient, it is a double-edged sword, as anti-TB therapy has been used in the past in the hope that it will improve Crohn's disease. And Cochrane review suggested the potential benefits in Crohn's disease with a lower relapse rate as compared to those receiving anti-TB treatment. There's improvement in symptoms and decline in inflammatory markers such as CRP. Whilst on the other hand, a retrospective study comparing patients with Crohn's disease receiving anti-TB treatment versus those who did not receive TB treatment, the administration of the TB treatment predisposed patients to stricture formation and the need for surgery, and this was not related to treatment delays. While patients with Crohn's disease who received prophylactic TB treatment with anti-TNF therapy had an increased progression to stricturing and penetrating phenotypes. So misdiagnosing abdominal TB and treating it with steroids or immunosuppressive therapy can lead to dissemination of tuberculosis. So early discrimination between these two entities is important. And if it's not possible, then TB treatment should be administered with close follow-up and early colonoscopy performed to ensure early assessment and discrimination. So on colonoscopy, the features that maybe may suggest that this is Crohn's rather than TB would be the presence of aphthous ulcers, longitudinal ulcers, cobblestone appearance, and anorectal involvement. While the features that may suggest that this maybe is TB will be transverse ulcers, pulsuous ileocecal valve, pseudopolyps, pseudopolyps and less than 4-segment involvement. While none of these endoscopic features are specific to each disease, other endoscopic findings like myonodularity and strictures do not have such discriminative value. The opportunity but what colonoscopy affords is the opportunity for tissue biopsy from the ulcer margin, and this should be sent for mycobacteria in culture molecular testing using PCR, apart from routine histology, which is what we generally will send the specimens for. Its microbiological assessment, histopathology assessment is challenging due to the overlapping macroscopic and microscopic microscopic histological features, and granuloma detection rates in intestinal biopsies vary, ranging from 10 to 80% in GIT TB and 15 to 65% in Crohn's disease. So what would differentiate the two would be in TB, what you'll find will be deep ulcerations. What you may find in TB will be deep ulcerations that are transverse and often circumferential and with ill-defined edges that are sloping, overhanging, with which are macrophage lined. While in Crohn's disease, one may find deep transmural fissures extending to the serosa, distortion of the mucosal architecture, pyloric mesoplasia, and hepatitis with abscess formation. In TB, you may find confluent caseating granulomas with acid-fast bacilli, while in Crohn's disease, the granulomas are relatively small, so microgranulomas. They're discrete, less frequent, and are found in 50 to 60% of patients, and they are found in 10% of uninvolved mucosa endoscopically. CD73 positivity on immunohistochemistry. In one study from India, they thought that it could help in discriminating between TB and Crohn's, as they said that it was only found in TB and not in Crohn's. While a local study from South Africa showed that CD73 positivity on immunohistochemistry was found in 52% of patients with TB and was found in about 30% of patients with Crohn's disease. The granulomas in TB are found in the surrounding intestinal lymph nodes in the absence of intestinal disease in TB, while lymph nodes are not present in the absence of intestinal disease in Crohn's disease. Microbiology is the gold standard for diagnosing TB, and positivity through acid-fast bacilli, culture, or PCR-based techniques. These techniques, however, have very low sensitivity, and acid-fast bacilli positivity in intestinal tissue is very low compared to sputum, with some literature stating about sensitivity of 5%. Culture can increase the yield of diagnosis, with reported rates of positivity between 70 to 79%. Radiological investigations that can be used include plain films, including a chest X-ray to exclude pulmonary TB, ultrasound, barium studies, CT scan, MRI, and PET-CT. Barium meal and follow-through and enteroclysis currently are not frequently performed. This is due to declining expertise in interpreting barium studies, a higher radiation exposure, and advances in cross-sectional imaging. This includes CT and MRI enteroscopy and enteroclysis, which allow for simultaneous assessments of luminal and extraluminal disease. The sensitivity of barium meal and follow-through in detecting Crohn's disease is 67 to 72%. On barium studies, the signs that are suggestive of TB would include the fissional sign, which is the thickening of the ileocecal valve lip and widening wide gaping of the valve with narrowing of the terminal ileum, which is also called the inverted umbrella sign. A pulled up cecum, a gooseneck deformity, which is loss of the ileocecal angle and dilatation, and dilated terminal ileum, which appears as suspended and hanging from a retracted or shortened cecum. The Sterling sign and the string sign are both signs that are found in Crohn's disease and should not be present in TB. And the Sterling sign is a conical or shrunken cecum, which is widely opened ileocecal valve, narrowing of the terminal ileum, and rapid emptying of the disease segment, and represents acute inflammation superimposed on chronically involved segment of terminal ileum, while the string sign is a persistent narrow stream of barium in the distal ileum. So a point-of-care ultrasound is an inexpensive and really available modality for assessing for bowel disease, and also looking for abdominal lymphadenopathy in the presence of ascites and looking at solid organs. Intestinal ultrasound for IBD has been used to look at disease activity and to see if treatment response by using color flow Doppler in the bowel wall. In TB, the features that you'll find on abdominal ultrasound include bowel wall thickening, abdominal lymphadenopathy, ascites, or mental or peritoneal changes, while in Crohn's, the bowel wall thickness is normally greater than 3 millimeters. There's an increase in color Doppler signals due to mucosal inflammation, and there's an increased hyperechogenicity in the mesenteric fat. Contrast enhanced CT of the abdomen and CT enterography have the advantage of evaluating intestinal and extraintestinal lesions, detecting early changes and subtle changes in both TB and Crohn's, and potentially differentiating active disease from fibrotic disease, and detect the fistulas that are more common in Crohn's disease than in TB. Necrotic lymph nodes have a sensitivity and specificity of 23% and 100% respectively in diagnosing TB, while the cone sign and skip lesions have a sensitivity of 82% and 86% and a specificity of 81% and 74% in diagnosing of Crohn's disease respectively. The changes seen at MR enteroscopy are similar to those seen at CTE. I think MRI ends the advantage of assessing perianal disease, especially in the setting of Crohn's. Neuroimaging modalities such as contrast-enhanced intestinal ultrasonography, small intestine contrast ultrasound, dynamic contrast-enhanced MRI, quantification of diffuse restriction by calculating apparent diffusion coefficient, and hybrid PET and MRI have been looked at in the literature to see if they can be used to discriminate between TB and Crohn's disease. So clinically to differentiate between, just a summary, just clinically to differentiate between TB and Crohn's, what one will find is that in TB, patient who presents with shorter history may have pulmonary symptoms and peritoneal involvement, while in Crohn's, the patient will have more of a chronic history with chronic diarrhea, hematochezia, perianal symptoms, or extraintestinal manifestation. On imaging in TB, one will find necrotic lymph nodes, a partialist ileocecal valve, asymmetrical mural thickening ascites, and peritoneal or mental involvement in pulmonary lesions. While in Crohn's disease, one will find mural stratification, fibrofatty perforation, comb sign, skip lesions, and log segment involvement. On colonoscopy in TB, one will find a postulus ileocecal valve, circumferential or transverse ulcers, while in Crohn's disease, one may find abscess ulcers, longitudinal ulcers, carpal toning, and skip lesions. While on histology, we'll find confluent granulomas, caseating granulomas, and ulcers lined with histiocytes on TB. While in Crohn's disease, one may find focally enhanced colitis, microgranulomas, and sparse granulomas. Model-based multiple parameters have been looked at in the literature since none of these investigations are 100% sensitive or specific in diagnosing or differentiating between Crohn's and TB. And they looked at multiple things like clinical features, endoscopy, histology, imaging, laboratory, to see if you could calculate these and you could accurately differentiate it between Crohn's and TB. And what has been found is that it's a sensitivity of about 90 to about 90% and a specificity of 92%. And excuse me. And then use of artificial intelligence is currently in vogue. This is by quantifying visceral fat and its ratio to subcutaneous fat that differentiates Crohn's from ileocecal TB. The ratio is high in those who have Crohn's disease. Another way is to look at the response to TB treatment. This is if all the available in the armamentarium still can't differentiate, then a therapeutic trial of anti-TB treatment can be used. The accuracy varies between 16 to 29%. The assessment of the clinical response alone may be misleading. So fecal calprotectin, which is better than CRP plus colonoscopy, can be used to assess the treatment response. Mucosal healing of the ulcers while on treatment is considered the gold standard in 2 months. Steroid or immunosuppression is not preferred in TB endemic areas because of a lack of clear endpoints and the risk of TB dissemination. So if the diagnosis is unclear after extensive evaluations, this is with clinical imaging, colonoscopy, histology, and microbiology, can look for novel markers if feasible. This would be like CT perfusion, visceral to subcutaneous fat ratio, or multi-parameter models. If the diagnosis is still unclear and if the patient is a candidate for surgery because of recurrent intestinal strictures, or severe recurrent pain or long segment strictures, then the patient will undergo surgical resection. If not, then the patient lives in the TB endemic area, then it's probably TB, and the patient will be started on TB treatment and then will be closely followed up for 2 months. If they respond to treatment, then they'll continue with treatment. If they don't, then you reconsider the diagnosis and you can repeat biopsy. If the patient does not live in the TB endemic area and the TB is unknown, then the patient is considered as treated as Crohn's disease. So the question is, does surgery have a role? Can the surgeons come off the bench like the bomb squad and do something in this dilemma of diagnosing TB, TB versus Crohn's or TB mimicking other conditions? So in this article from the World Journal of Gastrointestinal Surgery, they tried to look at what, and the article from the Royal College of Surgeons in England, they tried to look at what is the role of the surgeon in abdominal tuberculosis. And what they found is that the indications for surgery is in complications such as strictures, obstructions, perforation, and non-responders to treatment, in the setting of either subacute or in setting of subacute bowel obstruction, or in patients who have massive GIT bleeds. The surgical options are categorized into 3 broad main categories. It should be bypass of the involved bowel segment, radical resections of involved segment, or conservative surgery such as strictureplasties in strictures that are causing more than 50% of luminal compromise. Limited resection of the ileocecal segment instead of a right hemicolectomy is recommended. So if you look at, so in terms of surgery, in terms of a bypass surgery, the first figure 11 shows a stapled a bypass where there's transection, where the bowel obstruction is at the level of the ileocecal valve and the stapled proximally at the terminal ileum, and this is stapled side-to-side anastomosis on the transverse colon. The problem with this kind of configuration of a bypass is that it creates a blind loop in the segment of terminal ileum that's just proximal to the IC valve. So most surgeons would prefer the second picture, which is a hand-sewn side-to-side anastomosis without transecting the distal segment. Say the other option would be in radical surgery, whether one does a right hemicolectomy or one does just an ileocecal or a limited right hemicolectomy. And what the literature shows is that a limited right hemicolectomy, just resecting the ileocecal segment, is probably better than doing a right hemicolectomy or an extended right hemicolectomy. When it comes to the extent of lymph node dissection, you're doing such resections, whether one does a D1, D2, or D3 lymph node dissection. Since this is not an oncological resection, a D1 resection is normally adequate. And then the next question would be, how do we configure the anastomosis? Would you do a stapled or hand-sewn anastomosis? Is it isoperistaltic or antiperistaltic anastomosis? I'm going to just look at that in subsequent slides. And then when it comes to structuring disease, one can do a Heinrich-Makowitz, which is the top slide, or one can do a Finley structuralplasty. So the next question would be, is there a role for surgery in the elective setting in the diagnosis of ileocecal TB? This article published in the World Journal of Laparoscopic Surgery in 2021 looked to see if there is a role for laparoscopy in the diagnosis of abdominal tuberculosis. And they wanted to study the efficacy of visual impression of the peritoneal cavity by laparoscopy in the diagnosis of abdominal TB. They looked at about 50 patients. And out of these 50 patients, 84% had positive findings of findings on laparoscopy, characterized by enlarged lymph nodes, ascites, peritoneal tubercles, and interbowel adhesions. And then 76% of the patients had positive histological findings of TB PCR, and 78 of patients had positive gene express. So laparoscopic visualization of the abdominal cavity is 100% sensitive for the diagnosis of abdominal TB. And they concluded that laparoscopy is a safe and rapid method for the diagnosis of abdominal TB, especially if one has posed with a diagnostic dilemma. So as with all surgeries, we worry about the complications of surgery, and the complications would include anastomotic leak, fecal fistulization and peritonitis, intra-abdominal sepsis, persistent obstruction, wound infections, and dehiscence, reoperations that may be required for recurrent disease. Since TB mimics Crohn's disease and colon cancer, then can one take literature from those two conditions to decide how we configure our anastomosis to prevent these complications? So in this article from Australia, it looked at a right hemicolectomy for colon cancer and does the anastomotic configuration affect the short-term outcomes. And what they found is that both hand-sewn and stapled anastomosis techniques may be utilized for oncological right hemicolectomies with comparable rates of anastomotic leaks and postoperative bleeding. And then this article also looked at patients with Crohn's disease versus those with colon cancer. And what they found is that patients with Crohn's disease have a longer postoperative in-hospital stay than patients with colon cancer, but no difference in complication rates. And they postulated that it was because patients with Crohn's disease were younger, had a lower SA score, less comorbidities, and they're operated on by an experienced surgeon. Even though they had a longer post-operative hospital stay, their complication rates did not differ from cancer. Then how do we configure the anastomosis, isoperistaltic versus antiperistaltic, and does it really matter? And what this article concluded was that whether you did iso or antiperistaltic, the results were the same in terms of functionality, safety, and long-term outcomes. So can one then take this literature from colon cancer and then from colon cancer and Crohn's and then use it in TB? What we do know is that there's delayed diagnosis and indigenous treatment, and are principally responsible for mortality rates of about 4 to 12% in TB, and the contributing factors being malnutrition, anemia, and hyperbilirubinemia. And mortality rates are higher, between 12 to 24% in the presence of acute complications. So in the article from the disease of the colon and rectum, when they looked at surgical management of patients with GIT tuberculosis, they recommended that the initial treatment should be 6 months of TB treatment as the first line, and surgery only be reserved for complications. In a local study from Pietermaritzburg, published in the SAGS, which looked at lessons from emergency laparotomy for abdominal tuberculosis in the HIV era, they found that laparotomy is currently an option that we use for acute abdomen in patients suspected with HIV and abdominal TB. But this is associated with high morbidity and mortality, especially in emergency surgery. And emergency surgery should be really reserved for patients with convincing radiological and clinical evidence of perforation. In those patients who present with acidosis, anemia, and hyperbilirubinemia, and an unresolving small bowel obstruction is the most likely diagnosis. And more detailed investigation and minimally invasive sampling should be carried out if feasible. And this will help in deciding whether to opt for conservative trial of anti-TB treatment with intravenous nutrition support or proceed to laparotomy with its attendant risk. So in conclusion, I think ileocecal TB requires a multidisciplinary management and should be medical first, with surgery limited to the emergency setting or failed medical treatment in the setting of obstruction. And the role of surgery remains mostly in the emergency setting and should be minimal intervention instead of major resections. And in the elective setting, the role for surgery remains to aid in the setting of diagnostic doubts, in the form of diagnostic laparoscopy and biopsy, percutaneous biopsies, or even aspirations. And I think in the setting where it mimics other conditions in endemic areas, one should endeavor to exclude TB. Thank you.
Thank you very much, Dr. Sibiya, for a really comprehensive outline of it. Of course, I think many of the senior people in the audience will have been through some of what you've presented, especially regarding the sort of algorithmic diagnosis of tuberculosis. The first question from the chat, if you would try and expertly deal with it, is the gene expert. Everybody talks about doing the gene expert on specimens from colonoscopy, but what's the hard evidence that it really contributes to the diagnosis? That's coming from KK. I'm not sure who KK is. Do you have an answer for that one? Can you hear me?
Yes, I can hear you. I think from my reading, gene expert, it doesn't have, it's not, none of these investigations are very sensitive or specific, especially on bowel or on colonoscopy samples in diagnosing TB.
Yeah, I think there's a positive information on it and how it should be done correctly. I don't know. Yeah, so I have lots of questions because it is an interest of mine. I actually presented the Solly Marks lecture on this very subject. But perhaps, did you do the operation? I see it was a robotic operation. Why did you choose, or why did your senior consultants choose a robotic approach to this situation?
So, Prof, I think we are going to do what we generally do is a laparoscopic right hemicolectomy for patients with because we thought it was colon cancer,
Yes.
which was it was a locally advanced colon cancer. It was the N1 disease, so we went ahead with surgery. Since we don't have hard evidence in for neoadjuvant treatment in our setting, our MDT, this patient wouldn't really get neoadjuvant treatment, and we didn't have a tissue diagnosis. The reason why we did robotics, I think, was just because we had the robot available. There was there's no good evidence out there. I think the outcomes are the same when you look at robotics and laparoscopic right hemicolectomies. So we just used the robot because it was available, and she was going to be done on our next available slate.
With several people thinking that laparoscopy is a good diagnostic tool, did you ever think that you could perhaps, or were you just so convinced about the diagnosis of a cancer? Because those caseous nodes, the nodes looked very, shall we say, suggestive of tuberculosis.
I think, Prof, in hindsight, when we put in the camera with the robot, I think at some point someone said maybe the diagnosis is lymphoma, and then we were in two minds whether we should proceed with the right hemicolectomy because there are such extensive mesenteric lymph nodes. We ended up just doing a D2 dissection and not actually a D3 dissection. So even if it was cancer, we didn't actually do an oncological resection in retrospect when we got the diagnosis. So maybe the patient would have benefited from just a laparoscopy and maybe just a lymph node biopsy because the lymph nodes are so big and seeing. And then when we went back to look at the CT scan, I think we were so focused on looking at the lesion on the CT scan instead of looking at the lymph nodes and the characteristics of the lymph nodes. Then we then went back and said, maybe this does look like TB, but this is now with the final histology results.
Yeah. And some of the information that was published in South Africa was at the time when we were considering abdominal pain in relationship to patients with HIV without access to antiretrovirals. And there was a sort of an epidemic of those patients with subacute obstruction presenting. So the data that you quoted from Dr. Islam is from that period, but I think it still holds in terms of patients who are looking at it in areas where the incidence is lower, and obviously antiretrovirals are now widely used and widely available. So have you ever seen a case of ileocecal tuberculosis yourself before?
No, Prof. This was our first time I've seen it. I've never seen it before. We see quite a bit of Crohn's. It's in the young African patients, we're seeing quite a bit of Crohn's, but we haven't really seen TB. This is the first time I've seen it. And then subsequent to this case, I've seen perianal TB, which is very strange, also in the form of fistulizing disease, which we're still trying to work out.
And you said obviously in your conclusion that it's best for the gastroenterologists and the medical management to be the first line of treatment. Just because often tumors present to the surgeon, they're diagnosed by the surgeon, they never see a physician, or they may not, certainly in our setting. So what was the pathway to care in your setting, in your situation for this patient?
So this patient was referred to us not at Albert Luthuli, but at Pixley, which is the regional hospital, from Mahatma Gandhi, from them as a patient with a dysphagia for a workup for endoscopy via the upper GI guys, who then did the CT scan and then referred the patient to us as a CA colon that now we would then need to work up. And I think we just went that way of CA colon.
I think that's a real problem when you're not seeing the disease frequently as they did in the past, because it was obviously one of the top differentials. Now it's even after inflammatory bowel disease, which, you know, in 30 years ago would have been a much rarer occasion. But yeah, I'm glad that lymphoma came on to your diagnostic criteria, even if it was only in theatre. Yeah, there's what is the role for NGS as a method to diagnose between not NGS? I'm not quite sure what NGS is between CD and TB on areas where TB is relatively endemic. Maybe they mean non-caseating granulomas, but I'm not sure.
Hi, Prof. Shakil here.
Yes.
I think they mean next-gen sequencing. I'm not sure whether the question was directed to. I think there is a role, but the availability for next-gen sequencing is still, I think in certain labs only. We do have a lab that does next-gen sequencing for TB, only on research candidates, not widely available. So I think definitely it can confirm the diagnosis and can also pick up resistance as well. So it can direct and tailor your therapy. So very great if you have it. I don't think it's widely available in all other institutes, but definitely not in KwaZulu-Natal.
Yes, I think the technology is available in quite a lot of the universities, but it isn't being directed, or the clinicians amongst us aren't sort of pointing our diagnostic dilemmas at them as commonly as some other things are. Because I think COVID and lots of other things have pushed the agenda for and cancer work has pushed NGS. But so I think maybe there's a role for collaboration to see just how accurate this diagnostic modality is, because I do think for most of us it would be empiric therapy for her. Which brings me to another question. Having taken out this large TB mass, how long would you treat her for? Because you didn't treat her before. How long would you treat her for TB, or would you treat her at all?
So we are currently treating her, Prof, because we're treating her for 6 months with TB treatment. Because remember, I said she still has nodal disease, because we did leave some notes there saying that they are beyond a D2 dissection in the setting where we thought it was cancer, and that maybe we should benefit from adjuvant treatment if this is cancer for local control. So she still has nodal disease. So she still has positive TB lymph nodes. So she will get 6 months of TB treatment.
Yes, is there any experience with EUS to assist with the diagnosis of tuberculosis? That's from Dr. van der Skeef in Cape Town. Are you with us?
Yes, I don't have any experience with EUS. We don't really do EUS in our setting. We do anal ultrasound, but I'm not sure.
Yes,
for my
reading, I think that'll be more for the upper GI team. Generally, you can get sometimes pancreatic TB as well, and they can possibly biopsy from that. But generally, at the ileocecal region, definitely not. We're going to use EUS at that point in time. You could do targeted transabdominal biopsy for maybe acidic fluid, but not in the ileocecal region. I'm not sure of that.
Yeah.
If I can add the Shakil profits of EGA.
Yes.
I suppose it depends on the CT scan. So I think there's a fair amount of evidence for lymph nodes, which we can reach with a endoscopic ultrasound. So if there are significant lymph nodes in these sort of upper abdomen, iliac, or like peri-aortic, by all means, EUS has been used fairly effectively. The other differential there, of course, being a lymphoma, so you have to arrange with your heme lab to also arrange for flow cytometry as well.
Thanks for that. Yeah, I'm not sure if anyone else, if there are any other senior people. I see we have Christian Zouton from, I think he was on the call, from Cameroon. Do you see much tuberculosis in Cameroon, Christian? If you could unmute and let us know.
Yes, we have a lot. We have a lot of tuberculosis, but mostly peritoneal tuberculosis.
Yes.
Mostly here with ascites and so on, and we have the diagnosis by the function. And then for some time we can have some celioscopy, but usually it function and we suppose the diagnostic is there and we get to the treatment.
Yes, it's much easier to make the diagnosis with so-called wet TB, because that was the other distinction between wet and dry TB, and gastrointestinal TB and abdominal TB. I think there's quite a bit of clinical differentiation between these sort of entities, because remember, abdominal TB includes the liver, the uterus, and all the other organs that are in there, including the spleen, which can also be involved in isolation or as part of a pulmonary situation. Again, life gets easier if they have pulmonary TB, because you're definitely going to treat them for tuberculosis. So it takes out the need to confirm the diagnosis in the colon, other than if it's equivocal. So it's a good thing. But yes, do you use ADA to make the diagnosis of wet TB, or do you use laparoscopy much?
We prefer to use laparoscopy, and so we see the extension on the liver and so on before we decide.
Okay. Thank you very much, Christian. VG, your hand's up again.
Hi, Prof. Yeah, one of the things when you actually mentioned like in lungs, TB lungs, so something that we have been asking for, and it's sometimes a bit hard to convince the radiologists, is a HRCT scan. So you can actually increase your yield if the patient has a normal, like a chest X-ray. And you, in this situation of ileocecal ulcerations, query TB, query Crohn's dilemma, I think there was someone out from India at Sages a few years ago, Vineet Ahuja, and he actually ended with some sort of evidence that by adding on an HRC T scan, you can increase your yield for making a definitive diagnosis, well, at least your radiological, supportive radiological diagnosis of tuberculosis.
Yes. I think this whole AI interpretation, again, based on the literature of all these multi-system algorithmic sensitivity and specificity approaches, the AI approach might eventually get us there to something much more logical. Because I think still most people in Africa, if there's diagnostic doubt about gastrointestinal TB related to Crohn's disease, would prefer to do a trial of clinical of tuberculosis treatment and set a limit on it. And then if that doesn't work within a fixed period of time, then to move on to manage the patients as though they have inflammatory bowel disease. So do you think that's still the majority approach, VG?
Yes, I think you'd more often than not err on the side of starting the patient on anti-tuberculosis treatment, but the key there is then the follow-up afterwards, and it has to be objective follow-up. It isn't about how the individual is feeling. So generally, as was mentioned earlier in Sli's presentation, if you start patients with Crohn's on antibiotics, which in essence is what the treatment for tuberculosis is, they can actually improve. So you have to go back and do a repeat of the in our setting, most probably the scope. So you have to repeat the coloscope. And I think about a year or two at Sages, we actually presented the use of ultrasound, intestinal ultrasound, for follow-up as well, and we had a handful where we showed that the intestinal wall, like in thickness, had shrunk after 8 weeks of your treatment.
Okay. So I think we've covered quite a few bases there, and I think it's really good to refresh our memory that tuberculosis is around in all the countries, rich or poor, because of obviously migration of various individuals. And so we must be alert to the diagnosis and to sort of this reminder of what we can, how we can approach it and how we can best go about diagnosing it is really important, because the treatment is predominantly medical if we can get to a diagnosis that points us in the right direction. Interestingly enough, we presented a similar patient who was misdiagnosed as a carcinoma, who had 6 months treatment for pulmonary TB. She was HIV positive and she had a transverse colon cancer. I think we published that in the SAMJ, but it was a long time ago. But again, it illustrates that you can be caught just because you think the patient's been treated adequately. And I think that's another issue with the length of treatment. Everybody now is recommending only 6 weeks, but in the 6 months. But in the past, it was for longer than that, sometimes a year to 2 years in some people's eyes. But obviously, this carries that toxicity. So I think just remember that also some of these may be due to resistant tuberculosis and not due to the standard regimens. So that's another reason why the molecular diagnosis, which might give you some information on sensitivity, might be a really good thing if we can get a handle on it. So I think on that note, if there are no further questions, I think we've really done a round robin, and I'd like to thank Dr. Sibiya for presenting it, for the individuals who were involved in managing the patients, and VG as the head of at UCT for that. And I'd like to say thank you for putting your so we can actually see what Christian Zouton looks like. Thank you for putting on your and thank you for attending. It's always good to see other individuals from Africa in the same situation as us participating.
Thank you.
Pleasure.
Bye-bye.
So on that, I'd just like to say thank you to everyone else, to iEcho. Remember, this has been recorded and will be available on the website, the Gastro Foundation website, who have been the hosts of this for the past, goodness knows, I think it must be over 5 years now that we've been doing this. And remember to tune in next week when you'll have IBD, and then hopefully at the end of this month again we'll have a session on upper endoscopy. So thanks everyone, and goodbye.